You are watching a replay of an educational symposium sponsored by Sanofi and Regeneron, originally presented at the European Academy of Dermatology and Venereology Congress on September 17, 2025, titled Bullous Pemphigoid, Insights and Innovations. These are the disclaimers for this program. The learning objectives for this program are to discuss the complexity of BP clinical presentation, diagnostic challenges, and patient management. Explore the roles of autoimmunity and inflammatory pathways, including type 2, underlying the pathophysiology of BP. Joining us for this program are Professor Ulrich Raap, professor in the departments of experimental allergology and immunodermatology at Karl von Ossietzky University of Oldenburg in Germany, and Dr. Donna Culton, professor of dermatology, associate director, clinical trials unit director of the Clinical Immunofluorescence Laboratory at the University of North Carolina, Chapel Hill in the United States.
I'm going to be discussing what I think is the easiest part of this talk in terms of what we recognize, how we recognize BP, and understanding the toll it takes on our patients. And again, any of you who have treated a patient with bullous pemphigoid knows this well. Okay, so we're going to meet Mr. B. This is a patient that we will come back to throughout the presentations. So this is a 74-year-old male who presented to the clinic with itchy blisters on the trunk and extremities, as you can see in the top figure. His history included that he had a similar episode 7 years prior that actually required hospitalization. And so you can see those images along the bottom. So during that hospitalization, it was very similar in that he had tense blisters on his torso and extremities, but of course much more widespread. And his diagnosis at that time was bullous pemphigoid. And so of course when he came into the clinic with new blisters and erosions, he was terrified that he was going to end up back in the hospital. So as we all know, the quality of life impact is devastating to these patients. So we're going to hear from some of our patients now.
I had over 100 blisters. The huge blisters on my legs would start flaking, and I'd look on the couch and there'd be a big giant scab laying there. It was horrible.
It was mostly my hands like tweezers going through them, and it was very painful itch.
I started itching on my arms, and then it spread quickly to my legs, and it looked like little teeny blistering bumps. It felt like I got poison ivy. The itching was uncontrollable.
So no doubt those are things that you've heard in clinic before from your patients. When we think about bullous pemphigoid, we know it's chronic, relapsing autoimmune disease that's characterized by intense itch, inflammatory lesions, and blister formation. We all know, or we're trained, that there is a non-bullous, often a non-bullous presentation or phase of the disease, and that presents with intense itch with or without inflammatory lesions. The skin findings, if they're there, are typically eczematous or urticarial lesions. They last a variable duration, and the interesting thing is that some patients do eventually go on to become the more classic bullous presentation that we recognize more easily, but many patients do not go on to develop blisters. On the right-hand side of the screen, you'll see the more classic blistering presentation that we all recognize more easily. So again, intense itches there, tense blisters on normal or erythematous skin, and then just a reminder that in patients with darker skin types, that erythema can be challenging to recognize. So the epidemiology of bullous pemphigoid, we know that the global incidence is up to 76.3 cases per million, varies by region, of course. Prevalence estimates hover around 1%, but of course that varies as well. And both incidence and prevalence seem to be increasing. The age, we all know that this is typically a disease of the older patients. The majority of cases occur in patients over 60 years old, but both incidence and prevalence increases by about twofold per successive decade. So the older a patient is, the more likely they are to have this disease. And then, of course, gender, it can affect both men and women, and there does not seem to be a more common in one or the other. So we know that the underlying etiology is multifactorial and not completely understood. And this is probably the biggest question that we get asked by our patients: why did I get this? And it's hard to tell them. We don't really know. And so this is actually exactly what I tell my patients, is it's probably an environmental trigger in the setting of a genetic predisposition that triggers your body to turn on itself. We know that the cause is autoimmunity and that you develop antibodies against BP180 and BP230 that leads to these antibodies initiate the type 2 inflammation that we see, and that in turn, you'll get a lot more of this in the next part of the talk, leads to the BP symptoms and the skin lesions that we see. So we think about these triggers of disease. It's important to remember we should ask all of our patients about medications, because there are more and more medication-induced forms of pemphigoid being reported. And I would say, always it's wise to review your patient's medication list. But the top 3 on the list, again, you see the arrow going up, more likely. These are ones you really want to be looking for on your patient's medication list and thinking about as a possible trigger. So the dipeptidopeptidase 4 inhibitors, the gliptins, those are really important to be on the lookout for. Diuretics, as well as the immune checkpoint inhibitors, which of course that one's a hard one to miss on your patient list if you see it. But there are others reported as well that you can see here. So we're back to our patient. Now we're going to get into what else does he bring to us that we have to deal with, right? What else does he have going on in his life? So this sometimes is what makes treatment more difficult than it already is. He lives 2 hours away. He does not drive long distances, so it's very difficult for him to come into the clinic. He lives alone, and he manages his own medications, maybe or maybe not successfully. And then previously he was well controlled on a regimen, but he ran out of medications and he was lost to follow-up during COVID. So that was a crazy time for everybody, and we lost him to follow-up. So that was that 7-year gap when we saw him. So we, again, are kind of back to the quality of life decrease. So just the impact of having this disease on these elderly patients. We're going to hear from a few more of them.
I shield my back when I rinse it because the water pressure on the blisters is very uncomfortable. It hurts.
Depending on where my current infection is, it's painful to find a good position to sleep in without causing more pain. There were times at night that I had to change my pajamas 3 or 4 times because of the fluid from the blisters. My mother would apply bandages on me, and she had to change them every 3 hours at most. It was madness.
I stopped going out in the afternoons because the heat from the sun could really affect my blisters and make them more inflamed.
Sleep deprivation. It's pretty bad after a while because it makes you depressed. It makes you agitated, cranky, difficult to function.
So you can again hear probably your own patient voices in the voices of these patients. It's a very difficult disease to have and just to manage your day-to-day routines. We also know that bullous pemphigoid is associated with other comorbidities. So we know, again, over many decades of research that it's associated with malignancies, autoimmune and autoinflammatory conditions, skin infections, but on the other side, on the right-hand side, are things that we really need to be looking out for our patients. So neurological conditions has a really high association in patients with bullous pemphigoid, and then cardiovascular disease and diabetes as well. So all things that would impact your treatment of these patients. The pruritus, again, as we talked about, is perhaps one of the biggest burdens for our patients. So the blisters we talked about are difficult to manage for wound care purposes, but almost all patients have pruritus. And if you ask the patient what is the biggest problem with having this disease, most will probably tell you that it's the itch that is almost more difficult to manage than the actual blisters. We heard from a lot of the patients that it's worse at night. And again, the itch is more intense in the evening hours. Long episodes of itch lasting greater than 10 minutes, and again, can create difficulties in falling asleep and then causing patients to wake at night. So patients will tell you this. We heard from one of the patients that when he would go out in the sun, the itch was worse. So sweating, heat, and stress are all things that can aggravate. And you can see that mean pruritus score of 5.8, so that's pretty high. The take-home point of this slide really is to remind you that not every patient's going to present with blisters, but any older patient that has chronic itch, you should be thinking about bullous pemphigoid. So in addition to the physical burden, we need to really think about the rest of the burden. So the socioeconomic burden, you know, we have, I told you my patient who lives 2 hours away, his daughters would take time off from work to bring him to our visits or to try to be present during the video visits. It's a lot of impact on the caregivers and the family. Increased healthcare costs from home visits, lab monitoring, treatments, and increased rates of hospitalizations like my patient had. The mental health burden cannot be emphasized enough. So impaired quality of life, depression, loneliness, we talk about that a lot of these elderly patients will not go out with their friends anymore because they're embarrassed about their lesions, and anxiety about relapse, again, which my patient certainly experienced. And then there's the treatment burden. So frequent lab monitoring, safety concerns about the use of systemic corticosteroids and broadly immunosuppressive medications, and then again just the feasibility with daily administration of many of these medications we have to offer. In addition, bullous pemphigoid is associated with an increased mortality risk, and I think for a long time we thought, well, it's an older patient population and, you know, older patients are going to have increased mortality, but when we really look at the data, they have a greater than 3-fold excess mortality compared to their age-matched peers. And really what we want to know is what are the predictive factors of this? So who do we really need to be worried about? So it's an older age of onset, a lower kind of functionality score, the Karnofsky score, other comorbidities, some that we talked about, so cardiovascular disease and stroke, those patients don't do as well, and you can see many others here. High dose of systemic steroids, again, so something that we really need to think about as we're treating these patients. So we're back to our patient. He was diagnosed with recurring BP, and the plan was supposed to be an easy plan because we were just going to restart what was working for him 7 years ago, but we were trying to do this all over the video visits. We had a big plan where we were going to have his PCP do local labs. This all was a total mess, so none of it was happening as it should have been. So again, what should have been a simple plan just to restart him, again, all the social issues that were at play as well made it very difficult. So as we already talked about, BP has a lot of different clinical presentations that are very heterogeneous, which makes visual identification very difficult. So the main question for this slide is what would you do to further diagnose these patients? Many of them have blisters. Some of them do not have active blisters that you can see. But as we talked about, patients won't always have blisters. So if you're thinking about some sort of eruption, an older patient who's very itchy, how do we diagnose bullous pemphigoid? So the diagnosis is really based on the clinical presentation and medical history, which we just went over. But then what do you have to do when they come into your office to make the diagnosis? So typically we do 2 biopsies, biopsy for histopathology and then a biopsy for direct immunofluorescence, which again shows that beautiful basement membrane zone staining, so the linear staining pattern with IgG and C3. And then we typically do serological studies, so blood work to look for the presence of the circulating autoantibodies either by ELISA or indirect immunofluorescence. And so ideally you have supportive evidence in all of these areas when you're making the diagnosis. And so I think you can see from Mr. B that we have an unmet need for approved therapies for this condition.
It's my pleasure to tell you what's beneath the surface in Bullous pemphigoid. We've learned from the excellent talk from Donna Culton what is driving our patients with the symptoms and what is the histopathology. We can see the histopathology that we have a subepidermal blistering with eosinophils. And as a dermatologist, you know that eosinophils are never there in healthy skin. You know that from atopic dermatitis, but not in such huge accumulation as we can see in Bullous pemphigoid. And we have, this is a Th2-driven sign, and in this disease we have a linear deposition of IgG antibodies along the basement membrane. This is an autoimmune part. So, what is about these autoantibodies and where do these antibodies bind to and what are the protein structures? BP180 is a transmembrane glycoprotein that extends into the epithelial basement membrane, and BP230 is an intracellular constituent to the hemidesmosomal plaque. So if we have autoantibodies that bind to these anchor proteins, we have a detachment, and that leads to the subepidermal blistering, the separation of the epidermis from the dermis, and that's why we have these tense blisters. This is a clinical sign for the Bullous pemphigoid. If we look for the antibody levels, the autoantibody levels, you can see here graphs showing BP180 antibodies, BP230 antibodies. This is a normal, healthy serum. This is other autoimmune disease, and this is Bullous pemphigoid serum. And what you can clearly see that in Bullous pemphigoid patient serum, we have a significant increase of BP180 and BP230. And in addition to that, we also have patients with increased total IgE levels, and you can already speculate we have some low levels or normal levels and high levels of total IgE. And total IgE levels are present in 70 to 85% of patients, and we even have antibody levels to IgE of type BP180 and 230, at least in around 22% of the patients. And I will come back to you on the clinical view why this may have a role, for example, in non-Bullous pemphigoid patients. And what we know from several studies now that BP180 and BP230 autoantibodies correlate intra-individually with disease severity and activity. And to make it even more challenging, we even have anti-BP180 IgA antibodies, and this, of course, is a very rare type of IgA pemphigus. Antibodies, what do? They bind, but they also have the role with complement. So if we have a binding of the complement of the C1q to BP180 and BP230 IgE, then we have the activation of the complement cascade. And what does complement do? Complement activates eosinophils. It induces chemotaxis, but it also induces mast cell degranulation, maybe an explanation for this nasty itch. And we have a release of pro-inflammatory cytokines, which in turn attracts eosinophils again to the epidermis. In addition to this classical pathway, we also have an alternative pathway for complement activation. If factor B binds or autoantibodies bind to factor B, we have an alternative pathway of complement cascade. And again, we have a degranulation of several immune cells. We have an activation also of neutrophils, which are attracted by this pathway, and protease released to the epidermis, which also plays a role in the subepidermal blistering. The immune system, if we think of it in categories, we have 3 different categories, and the type 2 is the one who is classified for the Bullous pemphigoid. You know, everybody knows type 1 immune pathways. It's Th1 driven, and we have interferon gamma as a main key cytokine involved in this inflammatory response where viruses, bacteria, and anti-tumoral activity plays a role, macrophages and NK cells. The type 3 is associated with neutrophils, with IL-3 cells, Th17, and of course IL-17 release, IL-6, IL-22, 23, and we have the target roles extracellular bacteria and fungi. And now comes the most spectacular type, the type 2 type. We know it from atopic dermatitis. We have a Th2-driven disease, T follicular helper 2 cells, and we have a specific cytokine pattern with IL-4, 5, 13, IL-31, which plays a role in itch, and IL-27, TSLP, and IL-33. And we know that this type occurs in allergy, in helminth infections, parasites, and venom reactions. And we have, in addition to the Th2 cells, we have the innate immune system, which is really a strong activator in this type 2 inflammatory response with eosinophils and basophils, which are the prime early releasers of IL-4 in the skin, activating the T cells. When we select the type 2 cytokines and think about the roles, the big box counts for IL-4. IL-4 leads to the differentiation of the Th0 cell into the Th2 cell, also producing IL-4 by this, and also by increased production of IL-31. IL-13, in addition to the IL-4, is also able, like IL-4, to activate immune cells and to recruit immune cells to the skin tissue, form blisters, and of course induce B-cell proliferation and enhance the autoantibody production and the IgG to IgE class switching. Finally, we have IL-31, who's known for the sensitization and stimulation of neurons to release neuropeptides, but also is known for the induction of itch. And this counts also for IL-4 and IL-13, which are sensitizers for the sensory neurons to induce the itch. Just recently, our colleagues from China, Liu et al., published in Nature Communications a very nice paper pointing to immune stromal crosstalk, and they found that IL-13 and IL-13R1 alpha ligand receptor pair interaction is the most significant mediator in this immune stromal crosstalk in Bullous pemphigoid, in which Th2 cells release IL-13, activate fibroblasts, and then the inflammatory cascade is even sending a feedback loop again, stimulating T cells, so the inflammatory response gets really a boost by the IL-13, IL-13R1 alpha ligand receptor interaction. And we come back to the biomarkers. Do we have any biomarkers of this type 2 inflammation, and are they elevated in patients with BP? And there are some recent publications pointing out that CCL17 is increased in Bullous pemphigoid significantly, and it promotes anti-BP180 production, and with this epidermal-dermal separation, blister formation, and this is one of the biomarkers type 2 inflammation in BP. We also have total IgE and C16A specific IgG and IgE, and the eosinophils, which are often elevated in the serum, and patients with BP. We also have baseline levels of CCL18, IL-6 and IL-8, which were identified as effective predictors of disease severity, and we've got periostin. Everyone who knows Kenji Itsuhara from Japan knows that periostin plays an important role in atopic dermatitis in itch. And surprise, it also has a role as a biomarker in Bullous pemphigoid. So, biomarkers of type 2 inflammation, we have IL-4 and IL-5, which are elevated in blister fluids of BP patients, in addition to IL-31. And that explains why Donna Culton pointed out that these patients have especially itch in the lesions. And of course, these mediators promote further inflammation. It's a loop of inflammation recruiting other immune cells. And again, we have the eosinophils, neutrophils, basophils, which are also found in blister fluids in patients with BP. And again, we can see eosinophilic infiltrates in the superficial dermis, and inside blisters, you can see a huge accumulation of this fascinating immune cells, which release potent pro-inflammatory cytokines and neuropeptides, inducing inflammation and itch, and having a role in Th2-driven inflammation in Bullous pemphigoid. Finally, I come back to Donna Culton's presentation because she nicely pointed out that as a clinician, we see some patients that have just lesions like urticarial lesions. We can see erosions, but we don't see blisters. And what is the role for this? We don't know yet for sure, but this is a non-Bullous pemphigoid, which we can see in the clinics. It's around 20%, and they have elevated IgG autoantibody levels, and they have also peripheral eosinophilia, and this may have a role in this specific phenotype, which has been described by Barbara Horvath from Groningen and Marcel Jonkman. We also see in some patients with Bullous pemphigoid as a clinician mucosal involvement, and this is due to the autoreactivity against both the NH2 and the COOH terminal regions, which we can frequently detect in these mucosal lesions. And finally, we have some patients who are so severely affected, and Donna pointed out so nicely that serum autoantibody levels are correlating with disease severity in these patients. And of course, we have again eosinophilia and eosinophil activation, which is associated with a more severe disease.
To learn more about the science of type 2 inflammation and for additional educational resources like this one, visit adventprogram.com.